Welcome to today's podcast on healthcare inequities in America. I'm your host, Winfred Harris, a second-year kinesiology major on a pre-med track from Atlanta, Georgia. In a nation as developed as the United States, access to quality healthcare should be a fundamental right, rather than just a privilege. Healthcare inequality remains a major obstacle for millions of Americans due to factors such as lack of insurance, geographic barriers, financial limitations. Far too many people encounter unnecessary difficulties when trying to obtain essential medical care. My research often intertwines the use of terms such as healthcare inequities, disparities, and inequalities. Let me first define what those mean and why it's important in this podcast. The Center for Disease Control and Prevention defines health inequality as any measurable, often natural difference in health outcomes between populations. They also define health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that have been disadvantaged by their social or economic status, geographic location, and environment. And last but not least, health inequities. CDC defines that as disparities in health that stem from unjust, systemic policies and practices which limit opportunities for good health. The National Association of Free and Charitable Clinics explains that healthcare inequity refers to the unequal access to medical services and health outcomes among different populations. It often affects people who are uninsured or underinsured, live in rural or underserved communities, low income or unemployed areas, and members of racial or ethnic minority groups. The National Library of Medicine reports health inequality and inequity persist as pressing global challenges that disproportionately affect populations in low and middle-income countries. These disparities are driven by complex and interrelated factors, including socioeconomic deprivation, educational barriers, commercial determinants of health, inadequate governance structures, and systemic failures in resource allocation. You're probably wondering why this is a social problem, and the simple answer to that is that healthcare disparities are the result of intersecting factors, including socioeconomic status, like I once stated earlier, structural inequality, and labeling theory. And I want to break each of those down for you. Just starting off with socioeconomic status, lower income individuals often face barriers, including a lack of insurance, transportation difficulties, and high out-of-pocket costs. The Agency for Healthcare and Research and Equality put out an article that had a lot of good talking points. One of the things that they mentioned was that social class refers to groups in different positions within the social hierarchy, which was formed by economic and political reasons. Among others, there are objective differences in social resources such as income, education, occupation even, and often subjective differences in perceived social status among these groups as well. Many studies demonstrate that social class can positively predict individual health. Compared with the lower class, the upper class have longer lifespans, a better health status, and less possibility of suffering from a physical disability. I think it's important to note that there are many differences in socioeconomic statuses varying across countries. For example, Canada has a free healthcare system, and regardless of your socioeconomic status, you get equal access to healthcare. But in the United States, it's important to notice the difference between the lower class and the upper class and the advantages versus the disadvantages that they may receive depending on their class status. That also affects their physical health and their mental health. I want to take a second to highlight some of the research I did over this summer at a safety net hospital, Grady Memorial Hospital in Atlanta, where I worked closely with EMS, did a lot of ride-alongs, and I was just able to experience firsthand that a lot of unhoused people, due to lack of hygiene and just their housing environment, didn't receive the same level of care when it came to people who were housed or to people who had, people who lived in higher income areas. And that was a big issue that you saw, but then that goes back to the systemic factors, the political factors rooted in the governance structures in the United States and how social class just plays a role in the level of care that you receive. Whether it's transportation, whether it's lack of insurance, whether it's the high out-of-pocket costs, and just even factoring transportation once again, going back to those unhoused individuals, you see how different it is and you see how really hard it is once you're out there in person for them to really receive access to the medical care that they need because of where they're housed. I want to move on to the next concept, which is structural inequality. Just going based off some research that I found from Guy and Ford in their article, Structural Racism and Health Inequities among racial minorities are pronounced, persistent, and pervasive. And I want you guys to remember those P words because they're used strategically. Racism may be one cause of these inequities. Studies find that individuals who report experiencing racism exhibit worse health than people who do not report it. Health inequities are also seen in many outcomes, including infant mortality, heart disease, and cancer. A century ago, W.E.B. Du Bois recognized the connection between social inequities and health inequities, raising several central arguments related to racism, poverty, and other social problems. To that point, I want to point out a saying in healthcare that says, treat the patient, not the symptoms. And I think that's important to highlight when we're talking about structural inequality, referring to these systemic issues and the structures that allow them to still be at play. Just going back to the root of structural inequality, who really benefits from structural inequality? It's big corporations, big healthcare companies, those Fortune 500 ones that people like to mention in the news, United Health, State Farm, those mega insurance companies or pharmacy companies even, that really benefit from the structural inequality. But I want to bring it back to racism and segregation in health. Structural determinants such as poverty, educational and gender disparities, environmental degradation, conflict, and unequal allocation of health resources serve as primary contributors to the global health inequities. One of the forms of structural inequality is social segregation and racism. Some of the research that Guy and Ford also conducted, they announced that segregation refers to the separation of social groups. Most research on segregation and health disparities examines racial residential segregation, the geographic separation of racial group homes. And I want to tie that back into one of the last points that I mentioned in the most recent concept that I just talked about, which was socioeconomic status. And at the end of those points, I mentioned about housing status and how that really affected the type of care someone received. But then you see that again when we bring in racism and segregation. And that really raises the question, how do we really solve the structural inequality? And that starts with targeting those systems. As I said in the first quote that I mentioned when I started off talking about structural inequality, I said that studies find that individuals who report experiencing racism exhibit worse health than people who don't report it. And I know this sounds contradicting, but the best thing to do is report it, because without people seeing the discrepancies and the issues that are targeting minority communities, nothing will change. A lot of things are being masked by the structural mass that these corporations, the hospitals, the pharmacy systems, and the insurance systems put up. But without actually breaking those down and bringing those issues to light, then nothing will really change. The last theory I want to address or bring up is the labeling theory. As I learned in sociology class, labeling theory is an internalization that a person adopts to labels placed on them by society. The labels we assign to people can do more than just describe behavior. They can shape it as well. Within the context of health, labeling theory explains how medical professionals, institutions, and a society as a whole categorize individuals based on their health conditions, physical appearances, or lifestyle choices. This labeling process can significantly impact the individual's perception of self, as well as their access to healthcare resources and overall health outcomes. I think in society we get sidetracked. Labeling often contributes to health inequities and inequalities by perpetrating social hierarchies and marginalizing certain groups, and those groups are often minority groups, disadvantaged groups, people who are low income. Individuals who are labeled as unhealthy or deviant may experience reduced access to health quality care, which leads to those poor health outcomes that we talked about earlier at the beginning of the podcast. I also want to highlight an article called The Intrinsic Problem of Labeling in Healthcare, which was written by a researcher named Chen. And he highlighted that stigmatization and social stigma convey long discounted stereotypes and social discrimination in specific ways, resulting in an individual being psychologically categorized as unwelcome or an outcast, and in turn, notable differences between their virtual and actual social identity. And what that really means to me is that people can become dissuaded to get the health care that they really need because of the stigmas that society has placed and the stereotypes that society has placed. And you would think that, especially for someone like myself, I want to go into healthcare, I want to be a trauma surgeon. And just speaking from the experiences that I've seen in hospitals, there are oaths that doctors take, same with nurses. And, just going into healthcare, you would think that as people working with other people, treating people who are sick, injured, and who need to get better, that those stigmas wouldn't reach a hospital environment or a clinic environment, but they do. And that's the issue that needs to be addressed and changed. To recap everything from the podcast, I just want to remind you all that healthcare inequity continues to affect millions of Americans, particularly the uninsured and underserved, by limiting access to essential medical services. We are all impacted as a society when preventable diseases and unnecessary death can be avoided. The National Library of Medicine highlights that addressing global health inequity requires a transformative, ethically grounded framework that emphasizes justice, solidarity, and equity. I want to thank the National Center for Biotechnology Information, the National Association of Free and Charitable Clinics, the American Medical Women's Associations. I want to thank Chin for his article on the intrinsic problem of labeling in healthcare. I want to thank Easy Sociology. I want to thank PubMed as well for all their help and their contributions to making this podcast possible. Thank you guys for listening, and I hope that you guys can apply what you learned today by encouraging and supporting people, not only in healthcare, but really to speak out and address the global issues and the issues in the United States about health inequity and healthcare inequalities.